Hi, I'm Dr. Kelly Starrett, physical therapist and co-founder of the Ready State. I'm also a member of the Human Performance Advisory Board of H-Wave. What I want to do really quickly is talk about how I sort of conceptualize H-Wave usage with my patients post-surgery. What we can do is basically divide the sort of surgical experience into some discrete categories. And I'll talk quickly about why I think that this technology is vital to our sort of maximal healing timing and best outcomes. So first of all, one of the things that we know is that after initial trauma, oftentimes people aren't actually prepared for surgery or ready or appropriate for surgery because they have so much effusion that results from the initial trauma. So one of the things that we've done is realize that if we can decongest those tissues, have better joint range of motion, better pain management and control before a patient goes in, we tend to see better outcomes. So remember, what we're trying to do here is create non-fatiguing muscle contraction. So of course, the H-Wave device has some incredible on-demand pain relief, but I want to talk a little bit more about the magic of helping the body do what it needs to do, which is decongest. Now, after initial trauma, oftentimes we have limbs that are non-weight bearing, limbs that can't be loaded, and frankly need to be immobilized temporarily while those, because they're in pain or the trauma or can't move. So one of the things that we get fundamentally when we're working with H-Wave is what we call movement without motion. And so one of the nice things is the brain doesn't really recognize whether or not the limb is moving. Of course it does, but more importantly, it picks up that a lot of the features of that movement principle are engaged. So if my muscles are contracting, if I'm decongesting the lymphatic system, if I'm loading the fascia appropriately, then my brain still thinks, oh, hey, this is an isometric. So what we have here is ostensibly is low threshold isometrics that are done at 2 sort of contractions a second, which means that I can dial this up to a very comfortable level early on and start to put signaling back to the brain that it's okay to begin to load these tissues. And that's a really powerful, non-threatening input back into the system. So of course we're going to get decongestion because all that lymphatic, tubules, vasculature, lymphatic machinery is bootstrapped into the movement, but a system of the musculature. But if I can't move the limb, then clearly it's going to be more difficult for me to get the kinds of contraction to facilitate the draining and management of that effusion. Garbage out, groceries in is a simple way to think about it. So early on, what we've seen is that athletes have had traumatic ACL injuries, shoulder injuries. One of the things that happens early on is that we have this immediate effusion, immediate swelling. And when we're able to manage that, we actually have some kind of crazy outcomes where people are not having to take many pain management tools, opiates, even Tylenol, because they have very little pain secondary to their already high pain tolerances. But second, because they're not having a lot of swelling. And because we're actually able to get this sort of non-threatening input into the system, we have an athlete who's able to reconnect and maintain that neuromuscular connection. So that makes them more appropriate for surgery earlier, right? We have a better, healthier tissue system that's not going to be delayed from the effusion. Second sort of wave of our use of H-Wave is immediately post-surgery, when what we see is a lot of inhibition of regional musculature by the brain to protect the limb or protect the joint. And one of the things that happens is that if we wait around for pain management, for swelling to sort of naturally sort of dissipate, we see that more delay we have, it ends up creating a lot of downstream problems where we have sluggish quadriceps or poor rotator cuff activation, for lack of a better word. And one of the things that we know right afterwards is that if I can keep that limb tissue system plugged into the brain through contraction, then the brain is perceiving that that it's okay to move that limb, even though we may have the limb may be locked out, for example, or in a sling. So once again, we're able to get the sub-threshold isometric because the limb isn't moving, and we're getting a contraction that isn't going to disrupt a tissue repair, right? We're not putting this in hard tetanus. And if we do have tissues that need to be protected, we're able to decongest regionally by not even pulling on the affected tissue. So if someone had a biceps repair, for example, we don't even need to early on move the biceps because we can get the triceps and the forearm and some aspects of the pec and even the trap or lat. So early on, when we see, clinically, is that we have a lot of fear avoidance, that people are afraid to move because of pain, and it's real. If you've ever had a surgery yourself, you understand. And one of the things that we see is that the earlier we can get this sort of non-threatening movement system in, we have more desire to train, that more desire to move, and so that makes this rehabilitative process a lot easier because we're not sort of seeing all this pain guarding or certainly the anticipation of pain guarding. Additionally, what we have experienced clinically is that when we're able to better manage the congestion through this non-fatiguing muscle contraction by draining the limb, by draining the region, we're able to have, of course this is anecdotally, but our patients report a lot less pain management through opiates or narcotics or pharmaceuticals. So if we're not getting sort of blasted with this pain signal, of course people are going to have some pain, secondary to just from the surgery, so the surgical insult. But if we are able to manage the congestion, we end up seeing that we have less pain med usage, which is a net positive for physical therapists, for physician, and of course for the patient themselves. One of the other things is, and you remember this continuous passive motion machine around some of the knee replacements and knee surgeries that we used to use, is that we're able to get, again, a lot of movement into the brain perception limb system. And so what's happening then is not only are we maintaining neuromuscular control, we're able to manage perfusion better and effusion. But one of the things that happens is that the patient perceives that they are moving the limb and the tissues are being loaded appropriately. So when they actually go to actively move, we see that they have better control and less sort of rebound pain from this experience. So that has been very, very profound. One of the things that we appreciate is that we're trying to do a lot of things with the physiology. How do we manage and decrease risk of DVT, for example? And if we prescribe calf pumps to a patient, where the dirty secret in physical therapy, of course, is adherence to any good plan. And what we see is that it's impossible to get the number of cycles that we'd like. So if I'm telling someone to wiggle their toes or flex their butt or flex their quads every hour, 30 times an hour, well, if I'm at 2 cycles a second at an appropriate, comfortable level, that's 7,200 muscle contractions within a minute, or within an hour. So at an hour of H-wave usage gives me over 7,000 muscle contractions in an appropriate region or appropriate place. And you just can't keep up with the amount of sort of decongestion and movement that we get comfortably by using this device for an hour. One of the big problems we see is disrupted sleep cycling after surgery, where people are not moving or not even able to contract, and so they get behind on their swelling, they're immobilized, they're in bed. What we end up seeing is that they wake up in the middle of the night with a very, very swollen, very, very angry tissue. One of the sort of hidden rehab windows that we really like to exploit with our patients is during that sleep. It's very comfortable to sleep with an H-wave device on the affected limb. And one of the things we know is that pain gate or pain gates theory of pain modulation is if I'm getting movement, then my brain may not even be able to pick up on some of the low-grade pain signaling coming from the tissues. But add in additionally that if I have 7 hours of pumping during the night, that's over 50,000 muscle contractions. And that means that the patient is better able to wake up, has less, wake up ready to go with a less kind of a fused joint or tissue system, and they've been able to have a little bit more comfortable sleep because they're getting a little bit of movement in the tissues during the night, so that they're, the rest of the system hasn't gone quiescent and isn't just resting there, but rather, we've got movement in the limb that we're trying to sort of block from the brain from just sort of perseverating and hyper-focusing. So it helps us to avoid some of the sort of complicated pain science-driven related issues around chronic pain and persistent pain. And then finally, the kind of third management system of status post-orthopedic surgery is that we see that athletes are discharged or patients are discharged from physical therapy. Maybe they're only seeing their physical therapist once or twice a week, maybe 3 times a week if they have excellent care. But the problem is that they're going to continue to load, and we know that these tissue healing phases, even if they're discharged and returned to work, to rebuild the associated vascular networks of that limb system can take a long time. And so what we end up seeing is that we have patients who have been discharged and show up at our clinic sometimes after traditional therapy courses, and their tissues are very swollen, very effused. And so what's nice about having this in is that we have the H-wave can be used pre, it can be used immediately post to help manage some of those classic symptoms of post-surgical trauma and insult. But finally, on the other hand, is it gives our athletes and our patients a model and a method to continue to manage swelling as the tissues knit down, as they continue to heal, as we rebuild those vascular networks. We cannot have enough of our patients do kind of zone 2 low-grade aerobic work afterwards to really try to rebuild these capillary systems. So what ends up happening is that it's, for the average person, is that we end up beginning to try to say, hey, let's return to sport, and then the limb, the shoulder, the knee, the hip, these things tend to swell up, and then that puts that patient behind in terms of wanting to move or having full access to their tissue ranges. So we're able to continue to stay ahead as those tissues continue to mature at the 18th month mark. And what we end up seeing is that we have tissues that are better able to handle the loading because they're not kind of chronically, persistently effused for months and months and months. So again, when we're describing this to our patients, we say, here is our benefit up front. Post surgery, day, weeks of, we get a lot of benefit, and then that continues to derive benefit for our patients and athletes as they continue to return to their lives. So this is how we think a little bit differently potentially about using H-wave beyond sort of the on-demand pain relief of the high frequency, which of course is amazing when I'm trying to give someone some relief so they can feel up and move. But ultimately, I just want to reiterate and remind you that H-wave is a movement company, and what we're doing is facilitating a lot of movement without a lot of motion, and this turns out to be amazing.